Hello, everybody, and welcome to the second webinar from DJO. This is about the clinical guidelines and overview of our OA braces. And what I would like you to do is just some practicalities. I would like you all to pin me. So if you go up with the three dots and you can go in and put on pin me. Actually, I can't show it here. And you all have to go on mute. And I would really love for everybody to question will be in the chat. And the question will be answered at the end under Q&As. And I also have to inform you that this webinar is being recorded. So we're gonna, and sorry, I have to present myself. My name is Jette Misfeld, and I have been with DJO for 7 years. I am a product specialist and a physiotherapist in the eastern part of Denmark. And this was the practicalities, like you have to pin me, you have to mute all, and question, please put it in the chat and we'll wait to at the end of the session. And also, again, this webinar will be recorded. So the agenda today is kind of an introduction to the OA, where we have around the epidemiology, and then I'm going to go through some of the clinical guidelines. Going to take a little bit of the clinical data, not much, and then we're going to talk about treating OA from a DJO point of view, and then we're going to go around the VARUS and the VALGUS. I have a volunteer who has willingly want to show his legs, a very good legs for this session. Then we're going to talk a little bit about the OA braces. We're going to finish off with the Q&A and then the closing. If we see the OA around the world, it's going to be a very, very big problem, and it's continuing to grow. And what we see, and also from the WHO have made over the years, have seen that almost 25% of people that have turned 60 and above suffers from disability due to OA. Knee-OA affects around 40% of the European population, that is over 70%. It has not been in the former years. We haven't had OA as a disease, but it's more and more. Now we're going to see it more and more. And WHO expect OA to become the fourth most important global cause of disability in women and the 8th most important in men. Many people with pain in knee goes and get x-rayed more than they did before. So they have verified that knee OA is in more than 30% of men and women above 45 years of age. When we look at the risk factors, you can say that a very big risk factor in our society today is regarding obesity. We are not eating as we should, we are eating too much, and we don't exercise. So obesity is a very, very increasing actual knee load. We also now see that previous injury, for example, if you've had an ACL rupture, that you will get OA in an earlier age than a normal person without ACL. When you have muscle weakness, either due to loss taken by the muscle hands, that gives you more load on the knee. So if you don't have the muscle to hold your bones, you will have more likely to get OA. Also, we are getting older. The population, if you took, let's say 25 years ago, the average age for men and women were around 25 to 30 years younger than it is now. So we are older, and it's also wear and tear on the knees. Also, there is a difference between gender, so more women are likely to get knee OA than men. And of course, the malalignment is the primary factor that can put problems to the knee, and this is also where you have a bracing effect. But if we take care of the malalignment, we can indirectly affect muscle weakness and obesity, which are key factors to improve an OA patient condition. If we look at the international guidelines, and here it's divided into three. We have the OARSI, which is the Osteo Arthritis Research Society International, and we have the EULAR, the European League Against Rheumatism. And then we have NICE, that's the National Institute for Healthcare and Excellence. They have made guidelines, but overall, they also see that people with OA have to do exercises, they have to do a weight reduction, and what is very good for especially for DJO, is that we have the knee brace on a third place where the evidence is very strong. So if you look at the little scheme on the right side, you can see that the knee brace is strength of evidence is 67%. And this is very good because then you don't have to operate, but you can use the braces almost from an early time when you detect that there is OA on the knee. So if we look at the OARSI, they have made for the first time in 2014, they have developed treatment guidelines that is tailored to the different kind of patients with OA. These guidelines are based on a comprehensive review of the current scientific evidence for each treatment, safety and effectiveness. So, and in this case, surgical treatment, the cost of treatment, and the coverage by insurance were not taken into consideration when they made this guideline. If you look at, they divide the patient into 4 categories, but all 4 categories, then the treatment guidelines include these. And if you saw that the patient want to do exercise, this is where you are on land, but say walking, maybe not running if you're in severe pain, but you have to strengthen your knees. And for example, doing exercises in water is very good because you offload the entire knee, but you can still use your muscles. And of course, what is very important, that you self-manage and educate yourself around OA and what's good for you and what's not good for you. They also say that what I think is very, very, very important, that is that if you do your exercise, and also the OARSI found out that if you do the weight loss or the exercise, if you reduce your weight loss of your total body with 5% within a 20-week period, that has the most effective treatment of knee OA. But you can say do exercise, but what if you are in pain? Then it's very difficult to do the exercise. But they have divided into 4 patient groups, and this is the first one is people only with OA, and the second one with OA in the knee, and the second one is with OA in the knee, and they have all the following diseases. You can read them yourself, as diabetes, high blood pressure, heart or vascular disease, kidney failure, and so on. And the third group is also knee OA, but also in other joints than the knee. And the fourth one is the OA in the knee and other joint and all the other things. But what is really good for this is that in every single patient group, they put in OA braces as one of the treatment guides for the patients. Kind of going from we're not going to go into depth with the studies. I just want to tell you that there are clinical data to look at pain relief and the offloading effect of the knee braces. And the first one here is they have made a systematic review over 15 studies. And what I've highlighted in this one is that 98.6% of 567 patients had less pain. And there were also instant pain relief. And what the patient had to do was what it was that the patient had put on the knee OA to see, and for the medial compartment, not the lateral, but especially the medial compartment, because most of the patient that has OA is the medial compartment that has the most affected things. But what they found out is that in 8 of the studies that there was a significant improvement of the function. And if the function is good, then the patient can move more. And if the patient can move more, they will lose weight, and that will help for the knee pain. And what they also discovered was there were a decreased incidence of surgery in patients that were treated with OA. So actually you can push the OA operation further, so you don't have to be operated before it's absolutely necessary. And if we look at the second study, this showed that the pain relief we saw from the previous study is not due to some placebo effect. There are actual mechanics behind it. So 5 patients with medial arthrosis went to walk on a treadmill, and then they were using a 3D image of the joint with an X-ray. And they measured for most medial separation in 5 different points of the knee. And they made a fluoroscopic surveillance of the knee in the frontal plane while they performed a normal gait on a treadmill. And what they achieved was that the OA adjuster had a separation of 1.2 millimeters in the medial compartment. And just that makes it very good to use a OA brace, that it's not just placebo, but it actually works. And the last study, and it's actually quite new, it's from 2018. You had a patient walk with an OA defiance for 2 weeks, and then they went to a treadmill with and without the brace on. And what this study showed was that the patient with the medial compartment, they showed a significant increase in joint space and pain relief at the same time. So it's kind of a study that both shows the the first and the second study. If you want to know more about study, and there is a lot you can read about, we have summed it up in a brochure or a little catalog that you can get your sales rep or product specialist to get to you, or it could be sent to you on mail. If we look at DonJoy and the bracing philosophy, we always say that it's very good to have a brace, but if the patient don't wear the brace, it doesn't matter. But what is important is taking the patient into consideration when you choose a brace for the patient. And you should not treat the X-ray, which in some cases doctors have a tendency to treat the patient like the X-ray, but please treat out of what does the patient tell you? Do they have pain? Where is the pain coming from? And most of all, don't give the patient a brace they don't want to wear. And in DJO, we actually have where we say we have 4 barriers to motion. So if you want to go into exercise, well, if you have pain, you don't exercise. If you don't have the strength, you don't exercise. But pain, alignment, strength, and stability. If you look at those 4 things, actually in DJO, we have for the strength, we have multiple choices of for treatment, because we have, for example, we have our Dr. Comfort shoes where you can put in an insole to make alignment all from the foot and up. We have a complex or electrical stimulation for if the patient have difficulty in moving the muscles. We have our braces to give a better alignment in the knee, and all that results in less pain. Every time we talk about OA, we talk about the VARUS and the VALGUS treatment by DonJoy. And if we look at VARUS and VALGUS, most likely people are, the most sold braces are for the medial compartment that is affected. The lateral compartment we also sell, but it's not that much. And that has to do with the way we are anatomically built. So we have a tendency to get most in the medial side. So what our braces does, we have what we call the push effect. So if you have, for example, a varus knee where the medial compartment is affected, we push from the outside, it says from the lateral side, to open the joint on the medial side, and vice versa when we have the valgus. And actually, I would like to show you a patient now. And I would also, so I'm just gonna not share here. Okay, if we look at the knees here, and we have a line that goes from the hip and down to the foot, and we look at the line, we can see that we have some more pressure on the medial side because the leg goes like this, actually like the drawing you have. And sometimes you have a patient and maybe you're in doubt if they're gonna have a knee brace on or not. But we have a very simple method to show if the leg will move. Because if the leg won't move or the knee joint won't move, it doesn't matter if you put on a brace because the leg will still be in the same position. So what you can do, normally you do it from the front, but now I'm doing it from the back side, is that you put your hands on the side of the knee, and then you just push here, and you can see that the leg is moving. So in this case, you can put on a brace and have a good result. And many times when a patient, an OA patient, get a brace on, almost immediately when they try it on and have walked with it for around 10 minutes, they will feel a relief on the compartment that is affected. So in this case, I will put on a brace on the patient. You put it the wrong way. And remember to put the brace on the right way. So here we have the brace. Just very quickly. Remember the alignment on the top of the patella for putting the brace on correctly. And in normal circumstances, I would put the brace in a sitting position, but it's a bit difficult here, so please hold your balance like this. And right now, the brace in a neutral position. So what I want to do is I would like to make a pressure on the lateral side to the medial side. We have a pressure this way from the knee. We would like the knee to go that way. So what we have here, we have the adjustment here. And you can see by turning, this will pressure in on the knee here. And we do exactly the same on the calf. So we have 2 points here that make the pressure on the knee, open the joint on this side so the medial compartment will open up and you will get the pain relief that is necessary. Thank you. Actually, I would show you some of your the products, but I would like to show the difference between some of the braces and how we define if you should choose the different kind of braces. And it's a very good way for showing the rigidity of the brace, because it's very important when you have the OA. The brace that the patient I just fitted, like this one, is the OA Nano, but if you check the rigidity, it's a bit soft. But if you take, for example, the OA FULLFORCE, it's a little bit more stiff, and that defines which patient we should put the brace on what activity level it should be. I will return to the slides. Yes. And this is how the three-point load design works on the DonJoy. This is what I tried to show you in real life. Maybe it was not clear, but here it's more clarified here that you turn it and it pushes into, so the affected joint will open and you will get pain relief. This is I'm not going to show you all the products because we don't have the time, but we have an overview where we have a poster. And here you can see level of activity in the bottom. And you can see where you see early, mild, moderate, severe, that's it's around the OA. So if you have a patient that's really, really, maybe they have cartilage damage or and they really need stability, you should choose an OA defiance or an OA adjuster. Otherwise, it will go down from severe, moderate, mild, and early. And the early braces are, yeah, we call them braces. We have the Genoforce and the Trizone, which is actually quite good when people are just, maybe they have a little bit tendency in the knee and maybe they are not in severe pain, but it gives a very good compression around the knee and get them to move the muscles a little bit better. So I've chosen some of the big braces just to go through. We have the one that I showed on the patient, the OA Nano, which is a really lightweight OA brace. And this goes to moderate OA and not the severe. And if you have a very, very heavy patient, the OA Nano is not the right choice. But it's very good because it doesn't weigh that much. And for people that sees OA defiance or an OA adjuster and think this is too heavy, this is a very good alternative for the patient. And it still have the uploading effect up to 10% or 10 degrees, not 10%, 10 degrees. And if we have a more active person, who are more active in their daily life or a bit more heavy, then we have the OA Adjuster 3 that goes from moderate to severe OA. And this is a very good brace. The only, what you can say, if the patient doesn't fit into normal sizes, this is not the choice. Then you should choose OA Defiance, because then you can make up for the knee with the lateral offset, the thigh and the calf, so it sits perfectly. And the same, it has to a 10 degrees offloading effect as well. And it functions in the same way as the OA Nano. Then we have the OA FULLFORCE that is actually like we have in our normal 4-point braces, but we have put in a different kind of hinge where you telescopic the hinge right next to the knee and not on the side. But it has the same opportunity, but you don't have the same amount of correction, only up to 3 degrees of correction. But it has the point or leverage. And I must say, some patients don't need so much correction. Just they get a brace on and they get stability, they actually can feel pain relief. So it's not critical that you put it for 10 degrees or what. Sometimes a normal brace, 4-point brace, can do the trick as well. And the last brace is, of course, our custom-made OA Defiance, where you can adjust almost everything. The length of the thigh, the length of the calf, the straps, everything can be chosen. And here you put the correction, it's going to be built into the frame. And you also can telescopic up to 3 degrees more of correction in the joint. And here you are also, and I must say, if you choose a standard brace and you want to order and you look in the catalog, when it says medial or lateral, it's not the offloading, it's the affected compartment that you choose. So if you have a patient with medial OA, you should take a brace where it says medial and not the opposite. This sometimes get a little bit confused. Thank you very much, and then we go to Q&A. I got a question here. Says, which model would I use for the very good model I have on here? I would use the OA defines. And the reason why is the degree of what you call it, the degree of the angle of the knee is too wide, so I would use a defiance to hold, also because I know he do sports, and it has to, before it gets too bad, I would choose a defiance to hold the knee in place. Also because I know that the measurement is not good for a standard OA. So would you use a, can I see the questions? Yeah, sorry. This is all new to me, sorry. As another question, would you use OA reaction? In some patient with very mild OA, I would use the OA reaction because you get the proprioceptive constellation of the knee, and you train your muscle because every time you put something on the knee, you know, and we have seen in clinical studies that even if you put on a piece of tape underneath the patella, we know that biomechanically something changes. So an OA reaction is a very good brace for the patient who doesn't want to have a brace on, but should have something. So it's very good if you say you have a ladder you have to climb, so you put on an OA reaction. And another, what is the advantage to have all loading during the whole gait cycle? Well, we've seen in the study that when we look at the gait cycle, that the compartment is not the same measurement or distances, but what we have is, when we talk about OA, we talk about the cartilage, and if the cartilage is saved, then you don't have pain. So, and if we look at the one study where you look at the offloading effect, you can see that there is a separation in the joint, in the affected compartment, and under the entire circle of the gait. So it's good for the knee not to be pressured more than it should be. Any more questions? It doesn't seem to be. And if you're interested in this webinar, it has been recorded, and if you want to have it, you can contact Lisa, Elisabeth Søsum, and you will get a link to the webinar. Then I would like to say thank you, and thank you for the opportunity to talk to you all, a very different way of talking to people, and we are learning by doing. So thank you and goodbye.